Hey guys, welcome back to my channel. Today I'll discuss about AOGD March 2025 bulletin. First topic is alternative birthing positions. There are different birthing positions other than lithotomy. So we learn that. So labor is a process of dual emotions like unbearable pain and also happiness. So in developed countries, there are different alternative birthing positions being used. Currently, women who are delivering lying flat on the bed or semi-sitting position is generally we follow. But there are different positions where we can use like standing, sitting, squatting, side lying, knee and hand and knee position. This can be used. Why this alternative birth position is needed? Because if the mother is in pain and she want alternative birthing positions, then we should go for a respective maternity care. Whatever she says, we should respect that. And different positions can shorten the second stage of labor. Pain score will be less need of episiotomy. There is nutation and counter nutation it promotes. Like she'll respond to whatever you do, you say the commands and all. Okay, reduce rate of cesarean instrumental deliveries, reduce labor analgesia, Apgar score of the baby will be good, NICU admissions will be less, labor complications will be less, and satisfaction will be good, and birthing experience will be great for the mother. It will not be traumatizing to the female, so that she can plan for next pregnancy also with these different techniques. Okay. So what are the different alternative birthing positions? Simple thing. One is upright, second is non-upright. Upright means if you stand like towards the gravity, that is upright. Okay. Like standing, sitting on the chair, squatting, kneeling, all four positions. Okay, all four positions. And holding the bar or rebosa. Non-upright is like against the gravity, like side lying, lithotomy, dorsal position. Like whoever people lie down like this is against the gravity. Okay, so for them, these are non-upright positions. So why these alternative birthing positions are required? Because labor is a dual emotion one, and not only sitting posture, there are different postures which are required, which can reduce the complications. There are upright and non-upright positions, and generally we feel for a non-upright position, but there are different uh, upright positions as well. So upright positions major role, they play a major role in descent of the head. So see, these are different positions, like we can use a chair or stool, we can catch a bar. Okay, we can use a ball in this way. Okay, ball and rope, bean bag. Okay, ball and rope, bean bag. We can use tub or pool for hydro labor. Okay, tub and pool for hydro labor. What are the challenges in implementing? See, if we implement these in our government hospitals, many of the midwiferys doesn't know this. Even obstetrician does not accept this. Okay, so training is very important. Training is mandatory. How to support them and how to hold the baby if the baby deliver, how to hold that. Okay, and hydro labor is a separate method, and it is nowadays well accepted. And pain relief during hydrotherapy is also being seen, because why there is pain relief, there is less stress hormones, less chemicals which cause pain are released, less labor pain is seen. It shortens the duration of labor. Incidence of instrumental delivery is reduced and cesarean rate is reduced. Okay. ACOG recommends that no one position is mandatory. For example, if the lady is in a dorsal autotomy, then she can change the position. No one position is mandated. Okay, and you should avoid long periods of supine position. Okay, so these are different positions. Mainly, they are saying that upright positions, like towards the gravity, helpful for descent of the head and cervical dilatation. That is a good point here. Okay. Next, conclusion of this topic is healthcare professionals should know the benefits and consequences of both lithotomy and alternative birthing position. And key points is ease the delivery. The doctors, nurses, midwife should have certain knowledge on how to use that. And alternative birthing position should be encouraged. WHO also gives that. mm a pregnant woman can choose what type of position she need. Okay, and upright and lateral postures is associated with the second stage of labor, less pain and less instrumental deliveries, less episiotomy, less cesarean sections. Okay, that's about alternative birthing position. Now coming to the next topic, that is labor management in obese women. So obesity is something like if there is 30 of BMI or more than 30, 30 or more than 30, it is known as obesity. So how you which weight you will see? The first candidate will visit whatever weight is there, will calculate the BMI with that. And obesity is higher with in the Pacific Islands and Kuwait. In India, almost 40% of women having obesity. Okay, this is the classification. So underweight is, 18.5, less than 18.5, less than important. Okay, less than 18.5 because 18.5 is the normal one. So normal is 18.5 to 24.9. Overweight or pre-obese is 25 to 29.9. Then 30, from 30 onwards, I already told it is obesity class 1. So 30 to 34.9 is class 1, 35 to 39.9 is class 2, and more than 40 is class 3. Okay, so WHO class says that you should give folic acid to this obese woman about 5 milligrams. So we know that we'll give higher doses in neural tube defects, or if there is diabetes, or if the patient having previous history of any congenital anomalies or neural tube defects. But one more condition where you'll give 5 milligrams is obesity. Okay, these obese pregnant women have higher chances of preeclampsia, hypertension, diabetes, fetal microsomy, stillbirths also. Metabolic syndrome in the children born to the obese woman is seen. Okay, as the obesity is increasing, people, hospitals should have the large BP cuff, large wheelchairs, weighing scales, and all. Okay, appropriate ultrasound coaches needed for that heavyweight woman. And I already told these obese women have the fetus risk of neural tube defects, hydrocephalus, cardiovascular, orofacial, limb reduction anomalies, and all. Okay, the International Association of Medicine guidelines says that total weight gain, if it is 25 to 29.9, that is pre-diabetic, overweight, if it is there, then should get a weight gain of only 7 to 11. Okay, whereas if she's obese, she should get a weight gain of only 5 kgs. Okay, remember that. During pregnancy, if there is weight gain or weight loss, it doesn't affect the child. Like if your weight is lost during pregnancy, it doesn't affect the child. So you can advise the diet. Um, and ultrasound sensitivity is reduced in obesity because of so much of fat it can't receive the sonographic waves, so that is the one thing. And even the blood test can be different, like plasma volume is increased more in obese women, the serum analytes measurements will be affected. So the things, the hormones which should be raised in down syndrome will be not that much raised even though she is down syndrome. Even the cell-free DNA test values are disturbed. Okay, so obesity is something like BMI of more than 30. Like WHO says that you should give folic acid of 5 milligram because child born to these obese women have high chance of neural tube defects, and weight gain for obese, that is 30 BMI, is 5 to 9. Sensitivity ultrasound is decreased, even plasma volume is increased in them. So as I already said, told, the self-free DNA value test can also be failure, and these women of obese women should have tested for glucose tolerance and obstructive sleep apnea as well. And these obese women have less chance because of that. We have less chance of venous access. Even as epidural anesthesia is difficult, so nurses should see them during antenatal period, and they should mentally prepare before the patient. So that the date of delivery or whenever she comes, they should find the alternative methods. Okay, if BMI is more than 35, ultrasound can be used as complementary because we can't find the fetal heart rate with Doppler and the stethoscope. Okay, obesity is independent risk factor for stillbirth. Like if she's obese, she have double chance of having stillbirth. Okay, and in obese women, there is high chance of post-date delivery with higher BMI in the first trimester. And because, see, normal weight people will get spontaneous labor at the date of delivery. But obese women have less incidence, like 50% chances are less for the obese woman, mainly the BMI of more than 35 compared to normal BMI. Uh, ACOG is not, ACOG says that maternal obesity is not an indication of induction of labor, but RCOG says that better go for induction of labor at 38 to 39 weeks because there are high chance of stillbirth risk. So better go for induction of labor. Even in obesity, there is emergency cesarean section rate of 50%. Okay, yeah, and the if the lady enters into active labor for 4 centimeter to 10 centimeter cervical tension, it takes a longer time. Okay. In labor they should mobile. The lady should move. Obese women are less mobile during labor. Okay. And if she obese woman, she a history of previous cesarean section, then we can try VBAC to her. There is no such contraindications to her. Okay, and after delivery, mainly the class 3 obesity, that is 35, yeah, 35 BMI. If that is that, there is a chance of PPH after delivery. Okay, and obese women have chances of OSA, that is obstructive sleep apnea, so they have high chance of hypoxia, hypercapnia, sudden death. Um, Spinal anesthesia, when given in obese women, it reduces the respiratory function for almost 2 hours. Okay, so this is the thing. The cell-free DNA is affected. Glucose tolerance test should be done. Obstructive sleep apnea should be tested, and venous access should be taken before delivery. And post-delivery risk is 50%. Medical obesity is not indication, but RCO says you should do induction of labor by 30 to 39 weeks. Emergency cesarean section is 50%. Takes longer second stage of like active phase is more. Less mobile. These obese women are less mobile during labor. Class 3 obesity have high chance of PPH. Spinal anesthesia, if it once given, they can have a chance of respiratory dysfunction. Coming to antibiotics, people say that for the wound to prevent wound sepsis, at least 30 to 60 minutes before injection, antibiotics should be given. Okay, then choice of injection will be phenestyl or supra umbilical vertical or supra umbilical transverse. Okay, see this is the opacity. This is the panels. People says that the panels so the umbilicus is here. So supra umbilically only you can find it is above only the lower uterine segment is there. So supra umbilically you can go for incision. Okay. Mm, Cancer incision is most areas where is a controversial because of wound sepsis. Okay, supraumbilical vertical incisions are associated with increased pain and wound adhesions. ACOG and RCOG recommend that closure of subcutaneous wound if a depth of 2 centimeter. How much? 2 centimeter. If it's there, then you should close the subcutaneous tissue. Insertion of subcutaneous drain is not recommended. Vaginal cleaning before cesarean section, cleaning the abdominal skin, helpful for reducing the infections. If there is venous thromboembolism risk, the pneumatic compression device should be given. Early mobilization is advised. Prophylactic thromboprophylaxis is given in obesity, immobility, preeclampsia, fetal growth restriction infection. Generally, the thromboprophylaxis is 40 milligrams of enoxaparin is given 12 hours after cesarean section. Or if the weight you can't give according to weight, then you can give 0.5 milligram per kg every 12 hours. So BD dose of enoxaparin is given. Contraception depends upon the weight of the patient, and you should also encourage the weight loss counseling and healthy lifestyle in them. Okay, so there are different types of incision. Still, supraumbilical, vertical, supraumbilical transverse can be followed, and if the subcutaneous fat is 2 centimeter, better to close it, and better before doing cesarean, cleaning of the vagina and the abdominal skin by means of betadine helpful to reduce the infection. Okay, then. So the key points of this is there is BMI should be calculated in the first visit. There is longer first stage of labor. Class 3 women have high chance of PPH. Anesthesia should be seeing this patient antenatal itself. Stillbirth rates are higher. Mechanical thromboprophylaxis should be given. Wound infection rates are higher in obese women. And postpartum period should be utilized for healthy lifestyle and weight loss counseling. Okay, that's it. So raising obesity, there is high chance of cesarean section as well. That's about second topic. Now coming to third one, labor care guideline and evaluation. I'll tell in the next part. Okay. Thank you.